St George's is a large and complex hospital. There are multiple different teams that work within it, and they need to work together very effectively in order to deliver safe and effective care. You are all going to be part of these complex teams, so I thought it worthwhile to try and give you a heads up about the sort of things that can go wrong at St George's, so you can get some benefit from this experience to try and avoid these things happening with you as well. What you should see now is a chest x-ray. The chest x-ray was taken on the adult intensive care unit following the unexpected emergency admission of a 65-year-old man from theatres. He had gone to theatres following repair of a fracture of his ankle, which he sustained whilst walking. At the end of the operation, the anaesthetist was unable to extubate him, and so he was taken back to intensive care for further treatment. Over the next few days, he made very little improvement. There were issues with agitation and concern that his ET tube was not in the correct place. At one stage, his NG tube fell out and a new one was sited. This X-ray, taken to confirm tube position, was seen by many of the medical staff and nursing staff over a 24-hour period. And I wonder if you can see anything abnormal or unusual about this X-ray beyond the obvious lung opacity. When I've shown this X-ray in the past, almost everyone has spotted the nasogastric tube going all the way into the right lower lobe. However, this was missed by a large number of staff, all of whom were focused on other aspects of the chest X-ray. Unfortunately, by the time this had been picked up, the patient had been fed for some time. Although he made finally a very good recovery, the simple overlooking of the NG tube position will doubtless have set him back considerably and may well have contributed to a bad outcome in another situation. This is, of course, a so-called never event. Preventable never events such as this NG tube positioning can largely be avoided by close adherence to the NG tube policy, which, to summarise, insists that a chest X-ray is done to confirm NG tube position if there's any doubt whatsoever, using other mechanisms that would show that the NG tube is actually in the stomach. In fact, we have a large number of policies that have been designed often in the wake of a serious incident and learning from the serious incident that you would be very well advised to follow closely as they're born out of hard and difficult experience. The next slide shows a tray that's found in the CT scanner in the emergency department. This is, of course, the CT scanner that's popularised by 24 Hours in A&E, and it's where lots of patients pass through on their way perhaps from the helipad to the ED, or from the ED to the wards, and even from the wards and back to the wards again. It's a very, very hot scanner and is busy pretty much 24/7. A large number of different teams take their patients through this scanner, and the scanner is run by the radiologists. This is a photograph of this trolley taken just before the radiology senior trainee was about to insert a cannula. The patient in question had had a nasty footballing injury and had a foot with no pulses in. He was due to have a CT angiogram of the leg so that the vascular team could work out where the problem was and what they could do about it. However, when he arrived in the CT scanner, it was found that his cannula was no longer working. The radiographer then went out to prepare the cannula so that it could be easily inserted and then some contrast given. Because she was a very nice lady, the radiology trainee decided to go out and help the radiographer and took over with this trolley in this sort of position. As you can see, there's some a cannula there, there's some tape, there's some cleaning items, some gloves, all very good, and a syringe of something that we can be used to flush the cannula with. She inserted the cannula and then flushed it, but about 30 seconds later the patient looked quite frightened, then stopped breathing, then desaturated. Quite correctly, the team then called the emergency buzzer, and the ED staff came in to assist. It was very simple to re-ventilate and re-oxygenate the patient, but as soon as they stopped doing that, again the patient became apneic and the saturations dropped. It was sometime around this point that they realised that perhaps this wasn't saline in the syringe, but something else. The investigation was never able to be certain about what was in that syringe, but we suspect it was rocuronium rather than saline. The question coming out of this really is how one can end up giving a push of a fluid you're not even sure what it is, that's been unlabelled. But in some way similar to the first case, it all boils down to very clear communication and being absolutely sure what you're doing and making sure that everything is done properly. In this context, the trainee was simply trying to be helpful and had made the assumption that the radiographer had drawn up the fluid for her. Behind this, there were a number of other issues. Firstly, the CT scanner was poorly designed for the use of multiple different teams. So since then, we now have an anaesthetic trolley in that area so that drugs such as this can be put safely on there and not confused with other equipment. We've also made sure that the radiographer has time to tidy up the scanner between patients so that there are no potentially dangerous items left in the scanner for the next patient. The next slide shows a clip from one of many media outlets that reported the very sad story of Kane Gorney. Kane was a young man who had central diabetes insipidus and had been admitted to St George's for an elective hip operation. In keeping with protocol, he was made nil by mouth before the operation, but as commonly happens, the operation was delayed. The nursing staff had made the assumption that nil by mouth also meant medication, and he did not have any DDAVP during the time running up to the operation. Of course, Kane began to be more and more thirsty and started demanding that he be given water to drink. Rather than try and understand what was going on in context, he was felt to be agitated and was sedated. The situation then deteriorated, and even at one stage he made a phone call to the police saying that St George's was attempting to kill him. His hypernatremia, of course, gradually increased, and eventually he became more and more drowsy and comatose. He did not survive this episode. This story tells us several things. Firstly, because we work in a multi-specialty hospital, we often fail to take into account the needs of other systems and other specialties in managing a patient who has come in under our service. Diabetes insipidus seems to be one of these things where the patient can look extremely well when this is properly controlled, but can very rapidly get out of control with very serious consequences. Extrapolating this more widely, if there are aspects of a patient's care that you don't fully understand, make sure you get the proper opinion from the right person before making assumptions about what the right thing is to do. The next thing this brings into context is our sedation policy. Before sedating someone, it's important to understand why they're agitated in the first place. And patients should only be sedated if they actually are a risk to themselves or to others. Sedation should not be continued. It's potentially very dangerous medication, and therefore it should be reviewed daily. The next case is of a 45-year-old lady who presented with some left-sided pain. She was indeed a little bit tender on examination as well, and the ED team were concerned that she might have potentially some renal stone or some other GU pathology. She underwent a CT scan with contrast to better look at the kidneys, ureter and bladder. Now, I don't know about you, but I always have difficulty reading CT scans, so I tend to look for the report, and this is the report here. The report was seen by the ED consultant, and felt to show no evidence of anything serious going on in the abdomen. She was discharged home with some simple pain relief. Now this story tells us a little bit about how we should always be very careful to follow up results properly. We have a number of SIs in the trust every year, where essentially the information is in the system but no one's looked at it and acted on it properly. And this case well illustrates that. If you look carefully at the CT scan report, you'll notice the bottom of it is missing. And there was some vague abnormality reported by the radiologists, indicating that there potentially was a more serious problem that should be looked into. Unfortunately, this was overlooked by the attending team. And when she represented several months later, there was evidence of carcinomatosis all over her omentum, and this was, I'm sure, the source of the problem and the pain when she initially presented. Not only do we need to read the whole report, but we also need not to be blinkered in only trying to answer our clinical question, as often important incidental findings are found in our investigations. I have similar cases involving biopsy reports, blood tests, blood gases, and many more radiology reports too. In order to try and make some sense of all the learning we can get out of our serious incidents, our lead for clinical governance, that's Renata Wendler, compiles a monthly governance news at which the SIs that have been investigated the previous month are discussed and key lessons disseminated. So please have a good look at this for your sakes and for your patients. One of the areas that commonly gets picked up as an issue is managing confusion. We all too often tend to see this as a feature of dementia and overlook potential delirium, which of course has much more in the way of treatable options for it. The big issues that arise out of this whole area is of course capacity as well as diagnosis, and from that how we help patients who are confused, whether from delirium or dementia, to make decisions that are in their own best interest. Fortunately, there's quite a team to help you in this, and I'm not going to put the numbers up here, as these are all found on the intranet. Another area where we feel that we could do a lot better is around end-of-life care. Around 30% of the patients we admit, that's around 5 a day, are actually in their last year of life. Many would wish proper discussion and arrangement of their own medical care so that they can make proper decisions around this. For us, the most important thing to start off with is that we need to identify that actually our patient may be in the last year of life, and frank and open discussion is therefore appropriate. From this moment we can talk about DNA CPR orders, symptom control, and can involve the palliative care team. Again, they have a homepage on the intranet. We've already talked a little bit about never events, but it's amazing how many of these never events are actually surgical. Not wishing to get at surgeons in particular, I think this just simply reflects how much attention, quite rightly, should be placed on correct surgical procedures. Almost all of these seem to be based in communication or simple compliance with the procedure. And right at the heart of this is using a checklist properly before the patient is put to sleep. If you see theatre teams not doing this, please escalate this. Now, one of the hotspots for the whole hospital is the emergency department, pretty much like every large hospital. Over the years, we've seen activity slowly go up, and this becomes a serious problem for the whole hospital when ED fills up and no one can be assessed in it. For this reason, we've developed these ED standards to try and improve the flow of patients through it. Much of the issue was everything kept on being pushed back onto the emergency department staff, and specialists would come too slow to see referrals to them. So these standards have been written in order to ensure the right person is referred to, and that seeing a patient in ED becomes a priority for the specialist team. Once a patient's been referred to you, you can't refuse to see the patient. And if you feel that another specialty is better placed than you, it's your role to contact them and make that referral onwards. Well, I hope you haven't been too depressed by this list of problems and solutions that we've got at St George's, because actually overall it's a very safe hospital with very high standards. Most of the reason for this is our high quality staff. What you might find here is some different staff groups that you've not met before. These have been put here to augment the workforce and to improve both service and training. Some of you may not have worked with physician associates or these surgical nurse advanced practitioners, clinical nurse specialists, advanced nurse practitioners, or even sometimes FY3s. The key thing here is to make no assumptions about what someone's going to be able to do, as some may be far more experienced than you expect, or conversely, be unable to do something you feel is very simple. The key thing is good communication, being very clear about what you're requesting or what the other person is asking of you, and not making assumptions. So, I hope this has been a useful rundown of some of the key lessons that we've learned over the last years. And if you have any questions, please do not hesitate to contact me at this email address.